All right, so today we are going to talk more about ventilators, as this can be a very confusing subject, so hopefully this clarifies some things for you. So what do I need to know as the nurse about the ventilator or for the ventilator? As you gain more experience, you're definitely going to understand more about, what your client needs for the ventilator, the different modes and things that might be used for certain conditions. Just recognize, at this level, you don't necessarily have to know, okay, the COPD patient needs this kind of mode, or they need more volume or more pressure or less volume, less pressure, all that stuff. That's not what you need to understand. We as nurses don't decide, what mode to put the patient on. It's all doctor preference. The only thing we do need to know is about what mode to put a patient on if they're not breathing. So think about those emergency situations, that kill factor again. What's going to happen to, what mode is going to help a patient if they're not breathing? Because we definitely don't want a patient not breathing, not really knowing what mode to put them on. So again, we're really thinking more of those life or death situations or those critical situations. So let's go more into what we look at as the nurse. So, if I go into a room, I have a patient who's ventilated, we need to look at the patient and of course their assessment. So what's their respiratory status like? Are they using accessory muscles? Are they working hard to breathe? How is that ventilator working out for them? Does it look like they're working really hard? What color are they? Are they pale at all? Do they have signs of poor perfusion, poor oxygenation? Then I also can look at my cardiac monitor. What's their oxygen level? How fast is their respiratory rate? A lot of times when we're not breathing well or not oxygenating well, our heart rate compensates. Our heart rate goes up. The heart tries to pump faster to get more oxygen out. Also, because of some things on the ventilator, our blood pressure can drop. So I want to be looking at all of those vital signs. Then I'm going to go over and look at the ventilator. What mode is the patient on? Are they on a mode where they're breathing mostly on their own, or are they on a mode that, they're, getting some help from the ventilator? And that's really the level you need to know is, are they getting help from the ventilator? And, if so, how much? And we're going to kind of break that down. Then I look at what rate are they on, how many breaths per minute, how much tidal volume are they on? And we're going to go through each of these. So don't worry if you're like, oh God, I'm already lost. We're going to look at each of these. We also want to know how much FiO2 or oxygenation they're on, and then how much PEEP. And PEEP is another way that we, manage their oxygenation. Then also, reviewing my labs. What was their most recent ABG? What was it looking like? What was their PaO2? How were they doing? What's their pH? And then maybe a CBC if there's any infectious process or anything going on. What's their white blood cell count? Looking at those things as well. So let's kind of break down some of these settings. So first we want to look at, if we have a CO2 problem. So there's a couple settings that are involved with our carbon dioxide and kind of change some of our ventilation. So those two settings are rate and tidal volume. So, when I'm going over to my ventilator, I'm looking at this, I want to see what rate a patient's on. And the normal is going to be somewhere 12 to 20. If you think of it, that makes sense because that's what a normal respiratory rate is for a normal person. So, and the thing to know as the nurse, I don't need to go in and be able to say, oh, a patient needs to be on a rate, excuse me, a rate of 14 or something like that. But I just need to know, compare what their rate is to my ABG. And, if there's something abnormal about my carbon dioxide, then I can use that rate. I can go up or I can go down based on what their CO2 is. And I have this little rhyme here, the rate goes high, CO2 goes bye-bye. And what that means is that the higher my rate is on the ventilator, so let's say that I had a patient with a rate of 22 or something like that. That means that they, not necessarily that they will, but they could have a higher chance of having a lower CO2. So if their CO2 is really low, then I can decrease that rate. And the same goes the other way. So it says here the rate goes low, CO2 will grow. And in that case, so let's say that I had a really low rate. Let's say that they had the ventilator set to 10 breaths per minute or something like that. And then I'm looking and my CO2 is really high. Well, what can I do? I can increase that rate. And by increasing that rate and you're altering that setting, then I'm going to be able to change, how that patient is breathing. I can change, their carbon dioxide. Because if you remember, the rate of your breathing alters, your gastric exchange, how much oxygen you're breathing in and then how much CO2 you're breathing out. The faster you breathe, the more carbon dioxide you're going to get off. The slower you breathe, the less carbon dioxide you're going to breathe off. And this goes, whether a patient's on a ventilator or not. So this is just really saying, like when we're looking at these settings, I just kind of want to know what my patient's on. I can't look at a setting and say this is right for the patient just by looking at the setting. I have to look at their blood gas. I have to see how they're breathing. So that's really our role as the nurse. We're just kind of looking at these settings and seeing, is this working for my patient? Is it doing what it's supposed to do? Also, I look at tidal volume. This is how much volume of air the client is getting. Usually it's going to be somewhere around 450 to 600. It can be higher, it can be lower. Depends on the patient. It's really based on the client's height. Most hospitals I've worked at, they have a height chart and they do that. There are some that use ideal body weight and other things like that. You don't need to know about that right now. All you need to know is that the doctor sets this. They said this is how much volume that the patient should be on. However, if they're having a carbon dioxide problem, we can also change the tidal volume a little bit to try to help with some of that ventilation. Because again, if we have a CO2 problem, we have a ventilation problem. We're not getting the CO2 out. Or we're getting too much out. So, there's something going on there. So, in other words, if a patient is on high tidal volumes, they have more tide, they're going to have less carbon dioxide inside. And why that is because the more volume that a patient is getting in their lungs allows for more expansion and more gas exchange. So therefore, more tidal volume, larger volumes are going to cause more gas exchange. So there's going to be more blowing off of that carbon dioxide. Whereas if you have less tidal volumes, less stretch, there's going to be less gas exchange. So then there's going to be more carbon dioxide kept inside. So in other words, these go opposite, the same thing, like the CO2 and the rate and the CO2 and the tidal volume go opposite. So if one is high, the other one is low. So it's an easy kind of way to remember that these two are always opposite. So you always want to, do whatever the opposite is. So let's say that I had a patient that was on, 700 of tidal volume. They might have less carbon dioxide. So I can decrease their tidal volume and that might help to hold on to some more of that carbon dioxide. And same vice versa. If I was on a really low tidal volume, like 300, my CO2 was high, then what I could do is increase that tidal volume, and then it would help for me to get some more of that CO2 off. So it's all about, that ventilation process. Let's move on and talk about how we fix oxygenation problems. So if a client has an oxygen problem, there's two settings that I can look at on the ventilator and see if maybe the patient needs a little bit more support. Again, the nurse is not changing any of these settings by herself. She's working with her respiratory therapist and she has to, make recommendations to the doctor, but it's not, up to her to actually decide what's appropriate for the patient. It's just to help correlate this information. We're really just there as kind of that middle person to look at, hey, is what we're doing working? Because we're there at their bedside all the time. The doctor can't be there all the time, so we can say, hey, this isn't working, or hey, maybe that this might help this patient a little bit. So after I assess that patient to see how they're oxygenating, I'm looking at their oxygen saturation on the monitor. I'm looking at their ABG, at their PaO2, how much oxygen is in their blood. I'm looking at all of these things. Then I can, recommend, if needed, for a change to either the FiO2, which is the percentage of oxygen a patient's getting, or the PEEP, which is how open we're keeping those alveoli to help to increase oxygenation. So both of these settings are going to change my oxygenation. So for FiO2, this is the fraction of inspired O2. So it's a percentage. It's pretty much saying this is how much the percentage of oxygen the patient's receiving. So the least amount that a patient can receive is 21%, which is room air. The most they can receive is 100%. You can't go above that for FiO2 because there's no more than 100% oxygen on the ventilator. So the higher the percentage, the more support a client is receiving. So if I go in and my patient's on 100% FiO2, that patient's receiving a lot of support. They are on the maximum amount of oxygen they can receive. But if I go in and a patient's on 30 or 40%, that's not as much support. They're probably getting to the point where they might be able to, based on just that setting alone, they're not needing as much oxygen. So they're having less oxygen requirements. Remember, not everyone is on the ventilator because they are lacking oxygen. Sometimes there's other reasons for being on the ventilator. But it's good to know, what are my clients' oxygen requirements? And I want to compare that again to their ABG, to their monitor. How is that matching up? Are they on a whole lot of oxygen and they're satting 100%? They have tons of oxygen in their blood. Maybe we can turn that down. Or is it the other way around? Are they not on a lot of oxygen, or maybe on a moderate amount, and they're pale, their SpO2 is in the 80s, their PaO2 is low in the 60s or something like that? What is everything correlating together? If they're not getting enough oxygen based on my assessment, I could maybe talk to someone about getting that FiO2 turned up. Same with PEEP, we can do the same thing. The PEEP, remember, is that thing that helps to keep the alveoli open during exhalation. That helps to increase the oxygenation in the body. It allows for oxygenation to happen, and keep, especially during exhalation, where usually everything collapses, everything stays open to allow for more oxygenation. So the normal for this, everyone's usually going to be on about a PEEP of 5. That's the minimum that you put a patient on. However, it can go up to 15. And like I said, it can, I've seen people on 20, but that's really dangerous. So the thing is that the higher the PEEP, the more oxygen the support the client's getting. So if the patient has a PEEP of 5, that's normal. But if a patient has a PEEP of 8, 10, 12, 15, all of those are higher levels of PEEP, which is telling you, if you look at your ventilator and you have a higher level of PEEP for your patient, that's telling you, hey, maybe they're needing a little more oxygen support. So again, we're going to correlate this with what we already see on our monitor. What's their oxygen level on the monitor? What color are they? What's their ABG look like? What's their oxygenation, their PaO2 on their ABG? Once we correlate that, then we can see if any changes might need to be made. So if the patient's on higher PEEPs, maybe they're on a PEEP of 10, but they're on 100, they have 100% for their SpO2, their PaO2 is 300, they're getting plenty of oxygen in their blood, maybe we can turn that down. Or on the other end, maybe they're pale, their PEEP is only at 5, they're not, their PaO2 on their blood gas, it's low, it's like 50, so maybe we need to turn that PEEP up. So it's just pretty much saying, hey, if I have too much oxygen, I need to, if my SpO2 is high, if my PaO2 on my blood gas is high, if I'm not showing any signs of respiratory distress, maybe I need to turn down my FiO2. Maybe I need to turn down my PEEP. If I'm showing signs that I'm not oxygenating well, I'm breathing really hard and really working to breathe, pale, diaphoretic, my SpO2 is low, my PaO2 on my blood gas is low, maybe I need to turn up my PEEP. Maybe I need to turn up my FiO2. And again, these are decisions we make as a team for that patient. Something else to consider is that with PEEP, especially if your patient's on a higher level of PEEP, like if I come in and my patient's on a PEEP of 10, 12, or 15, I need to check what my blood pressure is. Remember all those complications with excess PEEP. I want to make sure that they're not having any other, signs of barotrauma or volutrauma, because that extra PEEP can cause damage to the lungs. So the last ventilator setting that I know I didn't mention on that first page, but that you're going to see on certain modes, specifically we're going to talk about PSV, or pressure support ventilation, as a mode. We could effectively, there is another setting that is called PS, which stands for pressure support. And this is how much push or support the ventilator is giving for breaths. So that means, like, even though I'm taking my own breaths, the ventilator is pushing in that air to take off some of that workload for me. So we only see this with certain modes. And the normal pressure support can be from 5 to 15. And so the higher the pressure support, the more support the client's needing. So in other words, if I'm on pressure support of 5, I'm not needing a lot of push. That's the minimum that we have people on. And if a patient has 5 of pressure support, they usually can be weaned off the ventilator if they're not on high oxygen settings. And so then if my patient's pressure support is 10 or 12 or 15, things like that, that means that patient, they might still be needing that ventilatory support. They may still need a little too much where they might not be ready to wean. So really we're just looking at those settings. And we're going to talk more about the pressure support when we get to that mode. So there are four main types of ventilator modes, and we kind of related these, to parenting styles in some ways. So let's look at them a little bit deeper, and we're going to break each of them down. But first, let's kind of look at them as a whole. So there's the CMV, which is the control freak parent, needs to have all the control. Assist control, which is assisting. So there's less of that control, but still holding on to, a lot of that control. It's not ready to let go yet. SIMV, which is kind of an intermittent or a balanced parenting style, and then pressure support, which is a supportive parenting style, but kind of letting that child, have a little bit more freedom. So this will make more sense once we talk about each of these. So let's talk about CMV. This is that control parent mode, that parent that wants to, take care of everything, to be doing everything. So in a patient that's on CMV, that's on the ventilator, we are going to set very, very strict limits for every one of those settings that we talked about. And when we're setting these limits, effectively, we're setting a minimum. So we control how many breaths or like how many breaths that they can take. We set a minimum amount. You have to take at least this many breaths. We set a minimum amount of volume. You have to take at least this much volume. We also set, how much oxygen they're going to get and how much PEEP that they're going to get. Most of the patients that are going to be on CMV are going to be medically paralyzed. Like, we are trying to do everything for them. And so effectively, we're trying to, let their lungs rest if they might have some really bad lung disease. Now, keep in mind, you don't necessarily have to know, hey, a patient has this disease process. This is the vent mode that they need to be on, because it's going to vary depending on the patient. Just understand, for this mode, this is a completely controlled mode. We are controlling everything, and we're saying you have to at least do this. You have to have this much oxygen, but we are completely in control, and we are pretty much setting them up like, hey, this is what you need to do. So let's look at what a ventilator would look like on CMV. So this is a patient that's in CMV. So remember, we set those four settings. So over here in this green box on the right, you can see where we set these four settings. At the top here, we have 14. That's their rate. They have to breathe at least 14 breaths per minute. Beneath there's the tidal volume, which is 500. They have to breathe at least 500 milliliters, of air with each breath. Down here we have a PEEP of 8 and an oxygen of 60%. So that's how much oxygen that we are going to deliver to them. Now, if you look over here on the left side of this screen, this is pretty much telling you, okay, this is in this orange box at the top, it's saying they're getting 500 of milliliters of air with their breath, which makes sense. They're getting at least that minimum. So they are just breathing right at that minimum. Again, then down below it says 14. That's saying that they are breathing 14 breaths per minute. So effectively, we're setting these minimums for them that they have to meet, that we think that will help them to breathe better. And yeah, we're going to be looking at their gases, their ABGs and things like that, and seeing how that's worked. We're going to be doing our nursing assessment, seeing if this works out for them. That's our role as the nurse. We can't just look at a ventilator and say, oh, looks good, or, this is appropriate for the patient. We have to look at the whole clinical picture. And you're not going to have to decide, again, whether something is appropriate, whether like they should be on this mode or AC or SIMV, because you're not going to know that. All you need to understand is that when a patient is in this mode, this CMV, they are completely controlled. The ventilator is doing all of the work, and we're really just trying to let them rest. So let's talk about AC mode. This is a mode that you're actually going to see patients really commonly in. So with this mode, we control how many breaths that a patient takes. Again, we're saying you have to take at least this many breaths per minute. We're going to set that on the ventilator. We also control how much volume they get with every single breath. So, what that means is that if the patient decides they want to take their own breaths, that they're going to have to take however much volume that we think they should have. So they always have to have that minimum amount of volume. We also control how much oxygen they have and how much PEEP they have. So this is very similar to CMV, which is why a lot of times CMV is not used anymore, because it's very similar to this one as well. But this mode, effectively gives an opportunity for clients to take their own breaths and kind of get a lot of that extra support. Maybe they still need that extra volume. Maybe they're still weak and still, working on trying to take bigger breaths. So this is a very supportive mode. And usually one for someone who needs that support still, someone who's still, kind of recovering from whatever reason that they, might be on the ventilator in the first place. So let's look at this. So this is obviously a different type of ventilator screen. I'm sorry I couldn't find the same one for all of them. I did try. So down here at the bottom, if you remember, I talked about how at the bottom of the screens is where we set it. This is what we're saying. This is what I want you to do. So I want this patient to take at least, see this F number? That's how many breaths. I want them to take at least 24 breaths every minute. And then right next to that, you see the thing that says V with a small t. That's tidal volume. So I also have set this machine, I want the patient to take at least 500 milliliters of air in each breath. That's the minimum that they have to take. Then over here on the right in the red boxes, you can see the oxygen I set. This client's on 45% FiO2. They're on 5 of PEEP. So that's what I want them to do. But here at the top of the ventilator, see it says F total. That's the total number of breaths. So I have set that I want them to take at least 24 breaths, and this patient is taking 24 breaths. I also have, this other one circled that says VTE, and that's the total amount of volume that the patient is getting with their breath. So remember down here, I said I want them to take at least 500 milliliters of air in each breath, and they're taking 522, so good for them. So they're meeting that limit. So effectively, if I was a nurse and coming in and looking at this, I could look at this that, their rate's kind of a little bit higher. Maybe I want to check, maybe their CO2 was high and they need to breathe a little bit faster to breathe that off. I don't know, but I could check my blood gas and see. They're not on that much oxygen support. 45% is not that much higher than 21%, so I could definitely consider that, and they're on the lowest number of PEEPs. That's just something I can kind of look at. So this is the things that I'm looking at when I'm looking at a ventilator. How much support am I giving them right now? How are they meeting that? But again, this is just a screen. I'm going to have to evaluate that patient, look at them and see, what they look like, from that, how they're tolerating it. So there's also SIMV, and so SIMV is, more of that intermittent mode. So this is that, parent that, is trying to let their child, have a little bit more freedom. So I can consider this the training wheels phase, where we're ready to let our kid, go and try to ride a bike, but we're not quite ready to, let them completely go. So effectively on SIMV mode, we're going to still have some control. We're going to control their rate. They're going to have to take at least so many breaths per minute. We're also going to control how much volume they get for ventilator breaths. Now let me clarify this real quick. So, when I have a set rate, no matter what, mode that I'm on, when I have a set rate, effectively the ventilator is set. So let's say my rate's set to 12. That means every minute I am going to have 12 ventilator breaths, which means there are 12 breaths. They are given by the ventilator. So that means they are giving me so much volume, so much support, so much push to get that in. It's always going to be the same. Those breaths are going to be the same. However, when you're on SIMV, the patient can also take their own breaths, of course, just like an AC. However, when they take their own breaths, they get to decide what they can do. So I know that's real. Everyone finds this really confusing. So I'm going to show some pictures in the next couple slides, and that will make a lot more sense. But effectively, the patient may have just ventilator breaths. They can have their own breaths, and when they do take their own breaths, they can try to breathe on their own. And so this is a great mode for a client that's maybe getting ready towards weaning, or might be ready to start trying to take some breaths on their own. We're going to be able to see like how well they can breathe when they are trying to take their own breaths, which is really helpful to know how they're doing on their own if the ventilator wasn't there to help. We're still going to control how much oxygen, and we're still going to control how much PEEP that they're getting. So let's look at some pictures to break this down. So this is a waveform of SIMV. So you see here, there's 3 breaths. They're these kind of like, upside down V's, or mountaintops if you want to look at this. Then look, see where this arrow is here in the middle of the screen? That's a patient breath. So look, ventilator breath, ventilator breath, ventilator breath, patient breath. Now look, it's a tiny little hill, which means that patient, they didn't take as much volume as they did, when they were helped by the ventilator. But you know what? That's okay. Remember, these are training wheels. We're trying to see what they can do. So you can see here, if you actually look at these numbers on the left-hand side, this is showing how much tidal volume. So it looks like their tidal volume was set to like 450 or something like that. So they got a 450 tidal volume, 450, 450. But look down here, when they took their own breath, they only got like, I don't know, 200 tidal volume, but that's okay. That was their breath. The ventilator's pretty much saying, hey, when you're taking my breaths, you're going to do what I say. But when you're doing your own breaths, remember what I talked about, was like you're going to turn a blind eye. Like they're pretty much like, my breath, so you got to do what I say. But if you want to take your own breath, you do what you want. So this is why that's that like laid back parenting style, where we're kind of letting them do whatever they're able to do. So this is a great mode to really see like, what can a patient do for themselves? Are they ready to start weaning? And here's another comparison kind of showing assist control and SIMV. So in assist control, you can see, at this top, see these things. You don't have to understand the waveforms and stuff like that, but just look. These 3 on the left-hand side, they all look the same. Here on the right-hand side, looks the same. Then there's this weird thing in the middle. That's the patient's breath. So, effectively, when the patient's taking a breath, it's going to look different because it's all of the patient's own work. So that's the thing you're going to kind of see that's a little bit different, is that, the patient may be taking those extra breaths, and they may be just as strong as the ventilator breaths, or they may not. It depends on the patient. But pretty much we're saying, what can you do? I want to see, what you can do when we don't give you that same support, when we don't force it. How much volume can you get on your own? And that's really important to know before we take a patient off the ventilator. So here's a picture of a ventilator on SIMV, and you can see it has a lot of those same settings just like AC. So it has the rate, the F number, 15. So that means I want the patient to take at least 15 breaths. Then under the VT, which is the tidal volume, we want them to get at least 650 milliliters of air every breath. And then on the right-hand side, you can see also the red box that has the oxygenation. They're only on 35% oxygen and 5 a PEEP, so not needing a lot of oxygen. And if you look up on those waveforms, you see those breaths, you see those tall hills, those are the ventilator breaths. And then those tiny hills, those are the patient breaths. So effectively, all you need to understand for SIMV versus AC, that's more for people that need a little bit more support. SIMV, that's more for someone maybe who's ready to start doing some weaning from the ventilator. Simple as that. And as the nurse, that's all you have to understand. And keep in mind, every facility is different. Some hospitals, doctors are just going to prefer one mode. So you always are going to look at the picture as a whole. But if you had to break it down and really keep it simple, AC, more support. SIMV, more of a weaning mode. So when we get to the point where we're ready to wean, we can talk about another mode known as pressure support. So this one's completely different than the other ones we've talked about so far. So in pressure support, they control how many breaths or the rate that they have. They control also how much volume they get. So this is brand new. Remember, up until now, we've been controlling their rate. We've been controlling their volume. Now it's all up to them. This is completely the patient. The only thing we're going to control is the oxygen that they receive and the PEEP, of course, so all their oxygenation. And we're also going to give them what's called pressure support. Remember how we talked about that? We talked about the PS as a setting. So we're also going to control how much pressure support or push that they're going to get in order to help get that air into their lungs. So let's look at this because sometimes it helps to break down. So you see here, look at what's missing down here. Down here by this, it says spont. That means they're spontaneously breathing. That's what that mode is. It's the same thing as saying pressure support. So you see there's no box here. That's because there's no set rate. There's no one telling them you have to take at least this many breaths. Pretty much it's however many breaths that they can take. Over in the middle, that red box is PS. That's the pressure support. That's how much pressure support this patient's getting. And remember, we have usually a minimum is going to be 5 of pressure support. And once we can go up to about 15 or so, and so the higher the amount of pressure support, the more support the patient's needing for their breathing. And then on the right-hand side, as always, there's your oxygenation. So looking up at the top of this ventilator, you can see that this is really important to look at. When someone's on spontaneous, there's no set rate. So I need to know how fast this patient is breathing. So F total is telling me what's the patient's respiratory rate. How many breaths are they taking? You can see in this case of this patient, they're taking 18 breaths. And then with that, the last breath they took, they got 560 milliliters of air in. That's pretty good. So remember, we kind of usually like to keep tidal volumes around, anywhere from the 400 to 600 range. When I'm looking at a ventilator for a patient that's on pressure support, this is the mode we use usually right before we extubate them. So when I'm looking at this, if people can be on this mode too and still need some support. So what I'm looking at here to see how much support the patient's needing is I'm looking at that pressure support. How high is that number? They're at 10, so they're needing some more support, and they're also on 10 of PEEP. So that's more PEEP than most patients. Remember, usually with PEEP, we kind of keep around 5. So if I was looking at this ventilator, they're on what we call 10 over 10. 10 of pressure support, 10 of PEEP. And so because of that, they're probably needing some support still, even though they're on a weaning mode, and maybe, hopefully sometime soon we can wean them. I can't pull the tube out right now because they're still needing some support. So, when you're looking at a ventilator as a nurse, you're really looking at, are the numbers a little higher or are they more on the low side? Because a lot of that's going to tell you how much support is the patient receiving. What is my goal for them today? Is my goal today to get this tube out? Is my goal today to wean the ventilator further, maybe decrease some of these settings? Is my goal today just to support the patient with whatever they're fighting right now and decrease that workload for them? What is my goal? So you're going to just be working on that, and that's not something you're going to understand overnight. You're not going to get some intricate questions where you're going to have to figure all these things out. This is really just for you to basically understand what some of these numbers are going to tell you about how to set goals for your patient that day. So let's bring this all together. There's obviously a lot more modes and more things to know, but I really just want you to focus on these basics. And I know this doesn't seem basic, I'm sure, but just realize that, there's not going to be incredibly tricky questions about this. We're really just trying to keep it simple and have you understand, as a whole about those, our role as the nurse as we're, monitoring this ventilator and trying to understand it. Most people are going to be on AC or SIMV. So those are the modes, really to understand the most. It really depends on the doctor. In the hospital that I work in, all of the medicine patients are on AC, all of the surgery patients are on SIMV, and that's a doctor preference. So it really isn't always sometimes even about, their readiness to wean. So you're going to learn more of this as you go on, and it's going to depend on your facility. But right now, for at this level, I'm going to try to simplify on the next slide a lot of the, generally what we use these modes for. When we're ready to wean, remember we usually do SIMV or pressure support ventilation. And your job as the nurse is really to prevent them from injuries and complications from the ventilator. And there's so many. We talked about all of them. Infections, skin breakdown, musculoskeletal issues, nutrition, neurological compromise. We could go on and on. But when you're going in and looking at that screen, you just need to realize, hey, my patient's on really high settings or they're needing a lot of support. They may have complications. So it's looking out for those complications. situations. Think if my patient's on a high PEEP, for example, I need to be watching out for hypotension. If my patient's on a high PEEP, I need to be watching out for the possibility of a collapsed lung or something like that, or some other acute lung injury. So it's just about knowing how we might need to focus in on some of these things. So really it's about knowing, what are high settings or what are not high settings. We need to be able to assess for oxygenation and ventilation. So regardless of what it says on that screen, what does the patient look like? How are they tolerating it? You don't necessarily need to know what needs to be done, how those settings need to be changed, but obviously if a patient's not breathing well, then we look at their ABG. What's wrong? Is it a ventilation problem, something with their CO2, or is it an oxygenation problem? Are they not getting enough oxygen? And then, another one of our jobs is going to be to wean as soon as possible. So, kind of knowing, based on the settings, are they on the, lowest possible settings? Are they at that spot where they might be able to wean soon, where they might be able to, tolerate breathing on their own? And then also a big role for us in managing ventilators is going to be managing that sedation and managing their comfort. So in summary, let's kind of break down these modes again. Effectively, CMV, this is a patient that needs a lot of support, usually medically paralyzed. Then there's AC, which is usually a patient who needs a good amount of support. They're going to, we're going to be controlling not only their rate, but we're going to be controlling the volume they get for every single breath they take. For SIMV, this is more where they're getting ready to wean. They're still needing some support, but we're starting to put those training wheels on and allow them to start taking not only just their own breaths, but their own volumes. And so we're going to let them finally start to do some of that work themselves. Then pressure support, this is where they get even closer to weaning. They're still needing, a little bit of support with that pressure support, but they're taking their own breaths, they're taking their own volumes 100% by themselves, aside from that little push that we're giving to help get that air in. So keep in mind with all these modes, the only thing you need to know as the nurse for these modes when it comes to knowing which client needs which mode is you need to know that if your patient stops breathing, they cannot be on pressure support. And why is that? Well, if they're on pressure support, remember, we don't give them a set rate. We don't give them a set volume. So if a patient's not breathing and there's no set rate and no set volume, that means apnea. So that means they're going to, stop breathing altogether, which means eventually there might cardiac arrest. So we definitely don't want that to happen. So if a patient's on pressure support, and maybe, remember we talked about in class, maybe you gave them some medication, it stopped them breathing, or maybe they had a change in their level of consciousness, maybe they had a sudden change. If a patient's on pressure support and they have a sudden change, if they stop breathing, they need to be put on a different mode. It doesn't matter which one, it just needs to be a mode that has a set rate and a set tidal volume, because we have to sometimes, if they're not breathing for themselves, we have to help them. That's the point of the ventilator. So we have to have a mode that has a set rate. That's the only thing you need to understand when it comes to that whole idea, because I know it's running through everyone's mind like, oh my goodness, how am I going to know which mode to put them on? The only mode that you have to say like, oh, this would be an appropriate mode is if someone's not breathing, they need to be on CMV, AC, or SIMV, one of those three. So I hope this was helpful. I know it's still probably a lot and hopefully it didn't confuse you more, but continue just to review this and do practice questions. And the more you look at it from a practical standpoint, from a question standpoint, it starts to make more sense. There's no way you can have this all memorized. You have to be able to apply it to a situation.